session of the paper of the thoracic. I'm Somcharan Sateng and my colleague, Dr. Apichat Tanta Walasin. Okay, today we have a total 3 papers. Unfortunately, the other maybe because of the virus, so he could not come here. So we would like to invite the first speaker. His topic about the non-prosthetic surgical repair for Pectus Excavatum in 500 cases. Dr. Hiroshi Ida. Okay, please.
Thank you, President, Chairman, members and guests. A revolutionary procedure for Pectus excavatum PE correction was reported by NAS in 1998 and gaining popularity. A convex metal bar is placed behind the sternum in this procedure, but the method has been associated with relatively high morbidity and limitation on patient age. We have improved our open repair procedure, and we review our experience with modified sternocostal elevation method we call SCE, with low incidence of complication and high patient satisfaction. From 1993, 506 patients underwent surgical repair or PE. Patient age distribution was 3 to 56. Patients suffer a psychological influence at age 5 or 6. Our procedure did not keep them waiting until puberty. Growth spurt in adolescence also cause prominent deformities. Our method can be adapted for adult patients. The surgical procedure has been improved over time. Sternal turnover and SC3 was discontinued. In our recent standard method of SC3, muscle with a median incision, the pectoral muscles were exfoliated from the lower sternum and cartilages. A xiphoid process were cut at the lower edge of the sternum. A part of the 3rd or 4th to 7th costal cartilages were resected aside the sternum. The lower tip of the sternum below 5th costal intercostal spaces was resected because this part is usually at the bottom of the excavation and exert pressure on the heart. Osteotomy on the upper sternal cortex in Lavich method is not used in our method. Cartilage stumps were drawn towards the sternum. All the cartilage stumps were resutured using heavy braided polyester suture. On the other hand, in Lavich method, only a part of the rib cartilage is resutured with sternum. The reattached cartilages and ribs generate 0.5 to 5 kg in pediatric and 1 to 10 kg in tension of 10 kg of tension in adult patient. The tension pulls the sternum laterally and caudally, such that the resultant force causes the sternum to raise anteriorly and also adjust irregularity and prevent frail chest. For adult patients with very severe asymmetric deformity, oblique wedge osteotomy on the lower sternal cortex was utilized to flatten the twisted sternum. This modification is SC3. The right lower edge of the sternum was resected in adult elderly patient with more severe asymmetry in SC5. I'd like to show you the photo and CT of the 15 years old patient had SC3. Post-operative CT indicate a remarkable improvement of his chest and heart contour. 3D CT showed the rib cartilages. The 3D CT shows shortened rib cartilages. This left part is shortened. And in lateral view, steep inclination of the rib were pulled up and become gentle. The angle between the vertebral column and the right sixth rib changed 56.9 to 60.3. Not only the depression of lower sternum was corrected, but also anteroposterior diameter of thorax increased after SC3. In all cases, the deformity was corrected satisfactorily. None of the patients require mechanical ventilation after emergence from anesthesia. Patient resumed all kinds of daily activities with 3 months of surgery. All the patients accepted and were satisfied with the result of the surgery. The length of the vertical wound was 3.6 in patient under 7 years old, and 6.7 centimeter in 16 years old or older. None of them developed pneumonia, deep wound infection, or any life-threatening complications. None of them had residual pain. No reoperation was required for any reason. Modified SC were adapted for various deformities. Deep cup type depression in 4 years old boy was corrected. This 56 years old woman was medicated because of severe chest pain. Chest pain disappeared after SC. Shallow and wide saucer type deformity was also corrected. This 6 years old girl hospitalized 4 times in the last 2 years before surgery because of pneumonia. She never gets pneumonia after SC. This patient had asymmetric deformity and history of surgery for pneumothorax on both sides. Asymmetry was corrected by SC4. Protruded costal arch was corrected by SC3. Slight change was seen, but no remarkable recurrence was reported. No patient needed to redo surgery. This is 13 years after surgery. NAS procedure made paradigm shift in PE surgery and took the place of Ravitch method. In recent paper, NAS procedure was not recommended for pediatric patients before puberty. Recurrence and complication were reported increased in patients before puberty and over 18 years old. NAS procedure has been associated with relatively high morbidity rate. Incidence of complications were reported to be around 10%. Residual pain is one of the unpleasant complications, and the patient has to get second surgery to remove the burr. We consider morbidity rate and limitation of daily activity to be important factors when evaluating the impact of surgical invasion. We believe that most PE patients maintain an acceptable quality of life preoperatively. Surgeons have a strong obligation to avoid the risk of complication and postoperative limitation on daily activities. Wader and Collins developed the original SC procedure for children in 1981. We have improved SC to make them less invasive and to adapt to various deformities and wide age range with low incidence of complication and have high patient satisfaction. We believe that modified SC represent a less invasive and low-risk procedure for repair of PE and offer an alternative for PE repair. Thank you for attention.
So, any comments from the floor?
Thank you for very good presentations. So I also do a lot of NASBAR. I prefer to do more like NASBAR, but this is fantastic result. So I want to have really short questions that if you have like asymmetrical tribe, is it different between the surgery technique or we should before this one only the symmetrical is I think it should be really easy. But for asymmetrical type, is it effective or is it same as or no?
Yes, this method is, I think, more effective than Ravitch method for asymmetric deformity because we resect a different number, sometimes different number and different lengths of the rib cartilages on each side for asymmetric deformity patient. And we use resilience of patient rib cage and resilience power works pull up the depression and the reaction of the pulling force will correct the deformity. So I think the asymmetric patient is most it's a good candidate for this surgery.
Right. So I have the second question. For the age, do you think which is the best age to do this kind of operations?
Yes, usually patient get a psychological effect on 5 or 6 years old, and patient rib cage got calcification after 30 years old. Yeah. So I mean, I think the 5 to 20 is the best age for this surgery. But we can do, if patient is older than 30 years old and the patient has a strong desire to correct the chest deformity, we can do the elderly patient. And we got good result for even for elderly patient.
Thank you.
Thank you very much.
I have a question. Yes. And are there any recurrent cases in your series?
Excuse me.
Are there any recurrence?
Yes. Yes. Little slight recurrence. We have a slight recurrence patient, but we don't have. But none of our patients need reduced surgery. Only a slight recurrence.
Thank you for your nice presentation. Maybe I missed one thing. What you use for the fixation of the rib with the cartilage with the sternum?
We use a heavy polyester suture. Number 1 polyester suture for pediatric patient, and number 3 very heavy suture for adult patient. Like it's a Japanese-made suture, but it's something like a Tycron or H-bone.
And one more thing like that, after the operation, what is the post-operative period? I mean, is there any specific rehabilitation or any specific physical exercise or any specific education for this type of surgery?
We don't, the patient don't need to get any special treatment after surgery. All of our patients don't need mechanical ventilation after surgery and usually go back to the ordinary world and work till tomorrow, day after surgery. And usually Japanese insurance system cover all the cost of the hospital and surgical costs. So patients tend to stay longer than needed, but all the patients discharged from hospital in 1 week, 7 days. The mean stay is 5.9 days in hospital.
Thank you.
So what do you use for the pain control of the patient? Because the bar is, I think, for our experience, is quite painful. So what do you use to control the pain?
Yes, we use epidural anesthesia for adult patient, but for pediatric patient, only the general anesthesia was used. And I think the cause of the pain in Lavitch method is intercostal muscle, intercostal nerve on both sides of the bar. We cut leave cartilage aside the sternum. It's a very so our patient don't have severe pain. We usually pediatric patient use a painkiller for 2-3 days, and even in adult patient, we remove epidural catheter in 3 days after surgery, and after that we use a painkiller only for 1 week usually. That's enough. Yeah.
So if no more questions, thank you very much, Professor.
Thank you.
Okay, move to the next speaker. Next speaker, Dr. Takaki Akamins. He will present the title, The Interpleural Distance Predicts Persistent air leak after initial primary spontaneous pneumothorax. Please welcome.
สวัสดีครับ Thank you for great opportunity for present our work in Chiang Mai. In this presentation, we would like to convince you the utility of interpleural distance to predict persistent air leak after the treatment of first episode of pneumothorax. We are hoping that our approach would help the management of pneumothorax in first episode. So in general, conservative treatment are followed to the patient with first episode of pneumothorax. And as you know, the recurrence rate is high, up to 55%. And on the other hand, although surgical treatment, but are demonstrated safe and effective, and low recurrence rates, and high patient satisfactions, initial surgical treatment to these patients are still controversial. So, however, once they fail to the conservative treatment, or in other words, air leak persists, a surgical treatment will be proceeded to this patient, even their first episode of pneumothorax. So the problem of persistent air leak is that it prolongs the hospital stays, which burdens patients and consumes medical resources. And also it's reported that the prolonged delay of intervention decreases the effectiveness of PATs. So the aim of this study is to investigate the risk factor of persistent air leak in patients with the first episode of pneumothorax for more effective management. So we retrospectively analyzed 122 patients with the first episode of pneumothorax who were admitted to Dissecting Fukuoka General Hospital from January 2011 to 2019. All patients were treated by a small bore catheter and treated to large pneumothorax. And definition of persistent air leak were defined as more than 72 hours. So we classified it into 2 groups, power groups and non-power groups. Surgical births were treated by uniportal or triportal. We estimated the size of pneumothorax by 3 methods. First is apex cupola distance in accordance with ACPP guidelines. And second, interpleural distance at Hiram in accordance with British Thoracic Society of guidelines. And light index, which are broadly used in European countries and calculated by the ratio of diameter of collapse length to that of hemithorax, inner hemithorax at Hiram. So in those guidelines, the large pneumothorax are defined as 3 centimeter, larger than 3 centimeter in ACCP guideline, and in British Thoracic Society guideline, the large pneumothorax is defined as larger than 2 centimeter of the interpleural distance. And this table shows the characteristics in patients with and without persistent air leak in first episode of pneumothorax. And both groups are composed by young adults, the mean age is 28 years old, and most are men, around 85%, and slender body types, the BMI are 20. And smoking rate is around 50%. And the hospital stays were in power group for 7 days a week, and non-power group were 4 days, which was significantly longer in power group, whereas expected data, yeah. And we also compare the pneumothorax size based on 3 methods between power group and non-power group. And the pneumothorax size of power group were larger than non-power group. A univariate logistic regression analysis revealed that the odds ratio for persistent air leak per unit increase in pneumothorax size was significantly high in 3 methods. This table shows only positive data, and the other factors were all negative. So this table demonstrated that the larger pneumothorax size was associated with a significantly high risk of persistent air leak. According to the ROCR curve analysis, the value of AUC of interpleural distance and light index were about the same and slightly higher than apex cupola distance. Because this interpleural distance is simple method and doesn't involve calculation like light index, so we further focus on this interpleural distance. And based on this ROC analysis, the best cutoff value of interpleural distance was 4.3 centimeters. So we set 4 centimeters as cutoff. This table shows the multivariate logistic regression analysis, the result of multivariate logistic analysis, which revealed that the only interpleural distance at Hiram larger than 4 centimeters was independent predict factor for persistent air leak. So in discussion, we would like to present the effective utility of interpleural distance in clinical settings. So in the British Thoracic Society guidelines, initial renal treatment will be followed to the patient with large pneumothorax, and to find that the interpleural distance at Hiram is larger than 2 centimeters. So if the interpleural distance of Hiram were larger than 4 centimeters, as we demonstrated that it has a high risk of persistent air leak, we should recommend that the early referral to thoracic surgeon and also consider early surgical intervention. In conclusion, we demonstrated that the interpleural distance at the level of Hiram is a good predict marker for persistent air leak in patients with first episode of pneumothorax. And this simple and useful method may help the management of treating a first episode of pneumothorax. Thank you.
So, any comments from the floor?
I think this is a very really nice. I would have like one comment.
Yes,
Do you normally do the CT scan?
Some patients didn't took a CT scan, so we didn't involve the characteristic of CT CAT scan. Yeah.
Because I think it would be the best if you include the study and put it the CT and show that maybe more than 4 centimeters have like picabule.
Yeah, that's
is
right.
You can see like this is really a high risk factor and to go into the early surgical one.
Yeah, that's as you said. And well, I also checked the CT scan. There's some were too much collapse of lung and difficult for detection of bulla. So in this study, we excluded the data of bulla. Yes.
Okay.
Thank you.
Okay, thank you.
Thank you for your presentation. I'd like to ask the duration from the onset to the hospital or chest rentgen, the smaller period.
Yes.
Or longer period?
Well, most were over 2 days. So 70% of patients were the onset from the admission was 2 days.
2 days.
Yes, and
it's a stable disease.
Yes, yeah.
Thank you.
That could be the bias. I know what you mean. Yes.
So, any comments?
Can I ask?
Yes, thank you.
I think right now they have one published from the journal that they say that they try to like a conservative treatment in the pneumothorax. I mean, in the asymptomatic cases. What do you think about that one? Even though they have you said about the interpleural distance,
Yes.
It's quite a bit high. They might try to conservative without surgery. What do you think about that one?
Oh, you mean the simple patient? Sorry.
The simple case.
Oh, simple.
Right, I mean,
Yes.
got a pneumothorax,
Yeah.
but no any symptom.
Oh.
Nothing to do.
Yes. Oh, we
So, and no
excluded
candidate.
from this study. And if in the clinic setting, I think we look just observe.
Yeah.
Yes, and doesn't treat. But if the pneumothorax get larger, maybe first initial drainage treatment, and after we discuss with the patient whether we do a surgery or not.
Because now we have the randomized control trial just published in a New England Journal. Did you see that they are in asymptomatic patient but have the moderate pneumothorax?
Yes.
So they just compare to observe and intervention, and they said okay, patient can observe safely.
Yes.
So how do you think about that? Moderate pneumothorax.
Moderate. Well, I think we first observe, not a surgical treatment. Well, thank you for the patient here.
Okay, thank you very much.
Thank you.
Okay. So let's move to the last speaker, Dr. Kazuhiro Aito. Oh, okay. Sorry for my. Okay, he will present. He will present in the title, Mirror Forceps for Dissecting Pulmonary Vessels During VATS. Please welcome.
Good morning, everyone. I'd like to talk about our lobectomy cases using mirror forceps. First, I will introduce mirror forceps. Second, I will show the VATS left upper lobectomy using mirror forceps. Then I will talk about our experience of using mirror forceps. Finally, I will finish with brief conclusion. The feature of mirror forceps is the smoothness of the tips. The surface is polished using electropolishing technology. It has blunt tips and single shaft with 5 millimeter in diameter. It is easy to insert within a narrow thoracic window. Then I will show the video of left upper lobectomy. The small nodule was firstly partially resected and revealed pathologically adenocarcinoma. This is the scene of fissure sparing using a mirror forceps. Mirror forceps was inserted along with the pulmonary artery. Then the lobe was partially spared, and mirror forceps was inserted to the dorsal space along with the pulmonary artery. You can see a tunnel to the dorsal space. The mirror forceps was inserted, and then the fissure was resected. First, pulmonary branches of A1 plus 2C was ligated and resected by harmonic scalpel. Then we are going to resect to the branches of upper lobe. The forceps was inserted along with the branches, dissecting. And then the mirror forceps was inserted behind the branch. The width of the opened mirror forceps was enough to insert the endostapler. So we do not have to over dissection of the pulmonary vessels. It will give us less dangerous. In the same manner, we are going to resect the A1 plus 2, A plus B using mirror forceps, and the endostapler was inserted and resected. Okay, then the superior pulmonary vein, mirror forceps was inserted behind the pulmonary vein, and the thin tissue surrounding the pulmonary vessels was ruptured by top of the mirror forceps. This is a so smooth technique, smooth sense, haptic sense. And then the superior pulmonary vein was resected using echelon 7 endostapler. And finally, we are going to resect A3. This is a dangerous artery for thoracic surgeon. But slowly, the mirror forceps smoothly inserted behind the A3. And safely resected by endostapler. After the pulmonary vessels were resected, the upper bronchus was resected and finished a completed left upper lobectomy. And this is our experience. We compared the postoperative time, operation time and blood loss and postoperative hospital stay before and after the introduction of mirror forceps. Operation time was decreased from 170 minutes to 162 minutes. Blood loss decreased to 29.6 grams to 21.7 grams, and postoperative hospital stay decreased from 9.6 days to 7.7 days. but there was no significant difference. In conclusion, mere forceps provided the careful control and secure manner in dissecting pulmonary vessels during video-assisted thoracic surgery. Thank you for your attention.
So, yes.
Steve Barnett from Melbourne. How do I get a set?
Fantastic.
How do I get it? Yeah, fantastic.
Yeah, thank you.
How do I get a set of the forceps? Where do I buy them?
This is your own design, that or this is a commercial one, that this middle forceps.
Middle forceps.
Yeah,
Yes.
the one that you show.
If I want
It's
to
just
buy
superb. I want to do what you do. How do I get the instrument?
Uh-huh. We can export from Japan to your country.
Yeah.
Yes. Yeah, you can use it.
So you develop this instrument by yourself, right?
By my hospital buy this instrument. You can access to the home page, but the home page is written in Japanese language, so you can't read them. But I will introduce you. If you have chance to come to Japan or Japanese Society of Thoracic Surgery, this company will make exhibit.
So it's only in Japan, right?
Yes, Japanese technology.
Oh, Japan
This
technology.
company makes metal processing. The Toyota, you know Toyota car? Toyota car の下請け、inferior company の、supporting company.
Maybe ask them to put it online so we can order.
It is possible.
So any question from the audience?
I think maybe it's not Toyota, maybe it's Lexus.
Lexus.
So when you're doing the dissections, when you use the camera, it's going to be like reflex. So it's a mirror, right? Is there any deflect from the light and blurring a lot of things from the video? But the video over is fantastic.
We stopped the upper light.
Ah, okay.
We are using endoscopic light only. So
But
it is not brighting.
I mean, like endoscopic with your instruments is the Miller one. Is it okay? Okay.
Fantastic instrument. Thank you very much.
Thank you very much.
So now all finished. So we have closed this session. Thank you very much for attending. ขอบคุณครับ